All right, we're going to get our next guest up onto the stage. Laura Rock is an intensive care specialist and pulmonologist from Boston, where she works at Beth Israel Deaconess. She also works at the Center for Medical Simulation in Boston. And she's going to talk to us a little bit from her perspective about patient stories in the ICU. And I wanted to start by looking at your Twitter profile, Laura. And it says that you're a believer in emotion before cognition. What does that even mean?
We all know from our own personal lives that when we feel overwhelmed by emotion, it's really hard to think clearly and make good decisions. And in critical care, we have a wide range of intense emotions in almost every encounter that we have throughout the day. I don't think we necessarily take the time to prioritize emotion before cognition. Sometimes we really can't. And when we don't, I think it's a missed opportunity for empathy, and I think it's frankly inefficient.
Okay. So you're talking a little bit about patients there and our interactions with them, but one of the things you and I have talked about is that these principles are pretty much the same when we're talking about our peer conversations, and we were talking about sometimes our inadequate responses when a peer expresses an emotion. So here I am, Laura, they came up to me and said, you know that patient you saw on Sunday? She came back on Monday with a big PE. And you're saying sometimes our responses to that are not so good, and I think you've got a little slide of some of the ones that might be possible.
Yeah, so I think that having empathic and even efficient responses to emotion is a teachable and learnable skill. And one of the ways I like to teach that is to make it much more personal and make it about us before we think about how we can do this for others. So I'd like to do a little exercise, and I would like each of you to think about if you said to a friend, a colleague, I think I messed up with a patient today. Think about how you would feel with each one of these responses. And if you don't see patients, just replace, student, researcher, whatever. Don't worry about it, I'm sure you did fine. Maybe you should get another job. You can't get around that with the number of patients you see. Your ratio is too difficult. Well, my day was even worse. That sounds tough. You want to talk? So I heard some laughter, but I also think each one of these responses is fairly common. Numbers 2 and 4 are sort of obvious don'ts. When you're encountering significant emotion, it's really not the moment to either offer sort of a task-oriented style of listening, unless they're really asking for advice, or shift the conversation to yourself. And I'd like to spend a moment on on 1 and 3. So in medicine, we like to fix things, and emotion is really no exception. And we often provide reassurance. The problem is it's called false reassurance for a reason. When we reassure, it comes from a place of caring, but it often manages to suppress the emotion that's expressed, and it precludes that person from really feeling heard. So it's really a missed opportunity. And then the other one I want to call answering feelings with facts. So when you provide information when you encounter emotion, which is something we love to do, information is our happy place, and we feel comfortable when we're offering facts and data and information, but when we do that, it is a missed opportunity to not only offer empathy, but actually uncover what are the values underlying that emotion that's expressed.
So this is like my patient says, I'm so worried about my chest pain. And I say, your troponin's normal.
Exactly. Exactly.
And then they repeat it. I'm really, really worried. And I say, your ECG's normal.
Exactly. So this could be as mundane as, Mom, I'm not going to school today. I have no friends. And you might say, of course you have friends. You were just invited to Sally's birthday party. So, as opposed to, that sounds tough. What's going on? So I think this is something that we all do, myself included. I have to remind myself on occasion to prioritize emotion before cognition and address the emotion before providing information.
Sounds like it could be handy for relationships as well.
Yes, it could.
All right, well, let's give us a little alternative here, Laura, and I might give you this to sort of talk us through. You've got
sure.
a better way of doing this, is this right?
Yes, so as I said, I think these are teachable skills, and one way that I've done that is providing this little mnemonic, which is entitled G.I.V.E. And the first step of G.I.V.E. is, frankly, just get that there's emotion there, and go there, drop your agenda, just listen, pause. This is a moment for connection, not information. The next step is identify. And this may be an internal step, so you may be identifying to yourself, wow, this person's having a hard time. Or you might say out loud, I'm noticing you're quieter than usual. The V is validate, which is really done through acknowledging the emotion that's present. So it may be, I hear you're worried, I'm worried too. I'm hearing you concerned about your chest pain. I get it, that's normal. And then the E is explore, to understand more. My favorite phrase, tell me more, or even more specifically, what scares you the most. So one example, emotion can often be really subtle. So when you're hearing emotion, either in the form of hearing the same question over and over again, or something that sounds really irrational, instead of answering with information, answering feelings with facts, you might try G.I.V.E. So I had a situation recently where I was teaching and I asked the residents for an example of something that was really challenging for them, and one of them described a really difficult conversation with a very, very sick patient who was still full code, full resuscitation, and the resident was having this code status conversation, and the patient's son said, can't you just write in the chart she's full code, but not do that? And he said, no, we can't do that. It's a legal document. We have to do what it says. So I think that is an example of a really missed opportunity. And here it might work like, that's a bit of a strange thing to ask for. This must be really overwhelming for you to make decisions like this and have this kind of conversation. Tell me, how would that help you and your family? And I think you'd learn a lot more, and you may do a lot to support his emotion at that moment.
Mm-hmm. So just to push you a little bit here, because it doesn't feel like that's going to be shorter or faster or more efficient, and I've heard a few quotes around there. Nothing 2 weeks in ICU won't solve 40-minute difficult conversation. But is it true? Do you actually get these conversations? Do you think it is more efficient?
Well, I think that having a patient in the ICU for 2 weeks when you could have really connected through recognizing their emotion and building some trust and making a different set of decisions through connection and empathy is a lot more efficient than having a patient with ongoing critical care who doesn't really collaborate with you in that process. Mm-hmm. And I think sometimes you don't have time to explore and have a long, engaging conversation. And sometimes when sometimes I joke with the residents that they're afraid to explore because they think it's going to take too much time. And half the time when you explore what scares you the most, it's about their cat. So I think, it may not require the time that you think it needs. And, I think one thing I like about this little mnemonic is that if you don't remember what it stands for, or you don't think you have time, it's enough just to give when you encounter emotion. And a lot of it could just be a nonverbal moment of pausing your own agenda.
All right, we're going to move on to storytelling in a minute, but Simon, this might be a good juncture to see if there's thoughts, comments about what we've spoken about so far.
I think a lot of people agree with you and would like to see those behaviors, but I think there's a lot of people out there who don't see positive behaviors under these circumstances. And there's a bit of a question about two aspects which I think might be barriers. One is time pressures and availability, and they feel that when the time is getting too tough, people resort to type. And the second is, how do you change your culture? So when you see other people doing poor behaviors, how do you influence to get them to do what you want them to do in this way? Or when people come to you and say, the conversation I've just had was not a positive one, how do you address that and change the culture in your departments and your organizations?
So I just want to make sure I understand the question, that if I notice other people not offering empathy and exploring and validating when they are encountering emotion, I think that it's really hard to change other people, but I also think just giving up is giving a lot of power to that negative dynamic. As Diana McLean-Smith argues in her book, The Elephant in the Room, she says, when you can approach a difficult dynamic with your own best self, you're really kind of diminishing the power of that sort of negative dynamic. And I think when you can break down these steps and model it, it can become a new culture.
All right, now you and I have got a shared interest in storytelling, and as we said, this session is about our patients' stories, and so I was hoping you would tell one that's a bit of a favourite of mine, and for us to think about not just the story, but the impact that that has.
Sure. I chose this story because we were talking about this theme of what can we learn from our patients, and this story helps me think about the power of our words, because I learned about the power or the importance of my words from a patient's wife. I'm near the end of a 14-hour day in the trauma surgical intensive care unit. My new patient was my age at the time, 34, vibrant, athletic, until now, healthy. I go find his wife, Rebecca, in the ICU family waiting room. As I'm introducing myself, she's cracking a joke about the circa 1950s artwork and the fact that the chairs are screwed to the floor. She's funny. She's warm and strong, and I imagine we could be friends if we met another way. My patient was helping a friend fix his roof. He fell off and suffered a severe traumatic brain injury. Now he's in the ICU, comatose, lined and tubed. While I'm speaking with Rebecca, she's digging through this seemingly bottomless olive green bag, looking for something she thinks could help me. I think it was her husband's doctor's name. She pulls out a couple of Matchbox cars, a bouncy ball, some crumpled papers, and finally she retrieves her wallet, and something drops to the ground. And I reach down and pick it up. A photograph. I see her husband and two children making silly faces. And stupidly, without thinking, I just say, I love seeing pictures of my patients. I feel like I get to know them a little, and through that connection, I somehow care even more, or try a little harder. It just came out. Next morning, 6 a.m., I'm rushing around the unit before rounds. I go in to see my patient, examine him, do my usual work, check the intracranial pressure, check the chest tube for air leak and fluid, gastric output, urine output, look at the vent, examine the patient. Suddenly, I look up and brace myself, just frozen. His previously white walls of his ICU room are covered, wallpapered with hundreds of photographs, leaving no remaining white space.
Wow. So I guess that story for you is pretty powerful. And I guess it means that you've thought a lot about these words, even if they seem to be empathic ones.
Yeah, I actually felt awful because I pictured Rebecca in the worst day of her life, having to go home, manage and love and care for her 2 children, dealing with the most awful thing that could happen to her, and then spending the entire night printing or finding photographs to help me care and try just a little bit more.
All right, well, Laura, that is quite the story, but I think it helps us all reflect on storytelling because, in fact, our patients' stories are very intertwined with our own. But I'd like our audience to please thank Laura Robb. Thank you.